my pleasure to introduce our next speaker, Professor الغار, and she will present to us four responder importance of AMH under clinical count, inter-site variability, case study, and discussion.
The colleague doctors are here. It's a short presentation. Don't worry, inshallah هنلحق الصلاة. Again, it's a case. She's a 39-year-old non-Egyptian, Mrs. B. I think she was Irish, married for 2.5 years with primary infertility, and it was a male factor. And she had already undergone 4 previous IVF cycles in Germany. The response in the previous trials, 3 cycles, they used a short protocol. They produced 3, 2, and 1 oocytes. And she had 1 long protocol, and there was very poor response with no egg collection. Her recent AMH was less than 1, and on the initial examination of the patient by ultrasound, the antifollicle count was 6. I counseled the patient, and based on the history, her age, her AMH, I gave her a success rate of 10 to 15%, and I totally agree with Dr. Gamal that we should be very careful when giving these success rates to our patients. And I suggested that we use the ultra-short protocol, the flare-up protocol, because this is what we usually do when we have patients with poor response or expecting a poor response. She was given the full dose, 6 ampoules per day, and on day 7 of stimulation, the right ovary was not stimulated, the left had only 2 leading follicles. We increased the dose, which we rarely do, up to 8 ampoules for another 4 days. And by ultrasound, we had 3 leading follicles and 3 small ones. We did ovum pickup. We had 4 M2 mature oocytes, and the lab had a comment on the quality of the oocytes. We had 3 fertilized embryos. The embryo transfer was done on day 4. 1 embryo was a 4-cell grade 2. 2 embryos were good. 8 cells grade 2. It was an ultrasound-guided embryo transfer. She was given vaginal suppositories for luteal support. After 14 days, the beta-HCG was negative. She came back, and she was counseled about the poor prognosis, because this was now her 5th cycle. With her age, with her low ovarian reserve, I counseled her. As a foreigner, she had the possibility to go back to her country and maybe do egg donation if she wished, but she wanted to try again another cycle at our center. So again, we used the same protocol, the ultra-short flare-up protocol, and I gave her a recombinant FSH this time, and just 1 ampoule of regular HMG. And this time, when she started the cycle, just before starting the cycle, the pre-cycle antifollicle count was 10. So just by ultrasound, it looked completely different this cycle, and I told her that it looked much better, and I hoped that she would have a better response. And actually, this is what happened. She did have a better response. On cycle day 8, she had a much larger cohort, about 13 follicles. On cycle day 13, she was ready for HCG. We had 7 follicles more than 18 millimeters. The ovum pickup gave 8 mature oocytes. 6 all were injected, and we had 6 embryos fertilized. On the day of transfer, it was on day 3 this time. She chose, I counseled her about the quality of the embryos and the number of embryos available, and she chose to transfer 2 embryos, 8 cells grade 1, and we had 4 cryo embryos grade 2. Again, an ultrasound-guided embryo transfer, vaginal progesterone for luteal phase support, and the beta-HCG after 2 weeks was negative. Of course, her response was different. It didn't differ in the pregnancy rate. She still has cryo embryos. We're transferring them this cycle. So I hope with our good results of our vitrification, maybe she will get pregnant. But it made me think that maybe these patients should be individualized. Maybe these patients should be assessed before each cycle, and we should start in the cycle that we see a larger antral follicle count. And looking through the literature, we know that that antral follicle count and AMH are both very important. The antral follicle, the female age had the highest area under the curve. Adding AMH and AFC significantly improved the model in predicting ovarian response. This was a meta-analysis of a large number of studies with more than 5,000 patients. And using AMH or antral follicle count alone had a similar accuracy to female age. But this is as regards the response. But if we want something to predict ongoing pregnancy, then age is the best single predictor. And the two ovarian reserve tests mentioned, the AMH and the antral follicle count, did not add much value. And I think this is what happened in this patient, that although she had a better response the second time, still her age and her age was the main factor in the prediction. And again, antral follicle count seems to be better in poor response prediction compared to AMH or FSH or to age. In this study, they mentioned a cutoff for the AMH of 0.9 nanogram per ml for AMH and a cutoff of 5.5 follicles for the antral follicle count. And this had actually a better sensitivity and specificity. But again, to predict the live birth rate, the age is the only independent predictor. And this is what I actually do in clinical practice. I see the patient and I see that the AMH is very low. And I'm about to tell her, maybe you shouldn't start the cycle or the prognosis is very poor. And then I ask her, I want to do an ultrasound. I see an antral follicle count which is maybe better than the AMH or it looks that would give better prognosis, and then I tell her, okay, then let's try. Maybe you will respond better than what I expect with the AMH. So I do agree that the antral follicle count is very important and might be better in these poor prognosis patients. Now, the center has performed, or our group has performed, 2 studies about the AMH. The first was published in 2014, the success rate using AMH. So we counsel the patient based on the AMH, if they should proceed or if they have a poor response. And using routine AMH assessment for patients with expected poor response reduced the cancellation rate and the stress. So if the patient knew from the start that by her AMH she has a very poor prognosis, maybe she chooses not to start, or at least she accepts that poor response and the poor pregnancy rate. We know, of course, that IVF has a very high economic burden on the couple, as well as the stress. She thinks that she's doing IVF, she's for sure going to get pregnant. She has a perfect pregnancy rate, and of course, in practice, this is actually not true. So I think using the AMH helped us to counsel the patient and give her an accurate or a near accurate success rate, so she knows what she is expecting. And from this study, and I will show it in our next study again, it showed that the low AMH had about a 50% reduction rate in the clinical pregnancy rate. So what I use this paper to counsel my patient, if the patient is a young patient, but for some reason, maybe a previous surgery, her AMH is very low, but she's young, and we expect her to have a good pregnancy rate, something like 40–45%, but because of this low AMH, her pregnancy rate, her clinical pregnancy rate decreases by about 50%. Now, do we have reports about intercycle and intracycle variation of the antral follicle count? Yes, this is a study by the Nottingham group in the White Journal, and there is an intracycle variation of the antral follicle count. We should check but when you check only the small follicles, there is a non-significant variation. It was more significant when we checked the follicles that were larger than 6 millimeters. So I do advise that we measure the antral follicle count and we stick to the small follicles that are less than 6 millimeters. And in this study, they measured the AMH as well, and as we know, there is not much variation or not significant variation in the cycle of AMH, and this is the main advantage of AMH, that you can measure it at any time. You don't have to wait for the patient to be in the 2nd or 3rd day of the cycle, and you don't have to wait for 1 or 2 cycles if she's been receiving any treatment. So how do we measure the AFC? Of course, by truly ultrasound. We advise that, most of the studies advise that we do it in the follicular phase, actually while the patient is menstruating, and you should measure all the small follicles. So this is how we do it. This is actually a PCO patient, and you can see that she has a very large cohort of follicles. You should ignore this dominant follicle. This is a PCO patient who is ovulating, actually. So it just shows that they do ovulate sometimes and get spontaneously pregnant. And you will just go through, you will take sort of a sweep in the ovary, and you will measure all these small follicles. And I think without counting them, this patient has a good AFC or a good antral follicle count. Of course, if you have the 3D facility, you will do automated antral follicle count measurement. This, of course, is a patient that's stimulated, so the follicles are large. But even if they are small follicles, you know, this technique, it takes a volume in the ovary and it will measure all the fluid, all the cysts, which are the follicles, and will give you a diameter and will give you a number. So if you have this facility, this would make it easier and faster. What would you do with a patient like this, a patient with endometriomas? Well, if you look carefully, you have follicles, you have normal ovarian tissue outside this endometrioma, and these are the follicles that you should measure. So you measure all the small ones, you ignore the corpus luteum, and you ignore these cysts. And in these endometrioma patients, of course, our policy is not to operate on these patients, to advise her to go ahead. It's obvious that this patient has a tubal factor because you can see both ovaries are stuck to the back of the uterus, kissing ovaries in the Doppler spout. So she definitely has a tubal factor. And of course, I would do AMH, but I would correlate it with the antral follicles that I see around this endometrioma. And in many of these patients, you find the antral follicle count is not bad. So you counsel her to go ahead and you give her the appropriate protocol and the appropriate number of ampoules based on this. Now, the inter and intracycle variability of AMH, we know that there is reports of intracycle variability between the follicular and the luteal phase. However, it does not seem to be significant. So again, this is the main advantage of serum AMH. You can measure it at any time of the cycle and counsel the patient accordingly. And this is this is another paper which talks about the AMH in late reproductive age, in older women, that maybe women that are approaching menopause, or 40 and above, the AMH levels are substantially reduced, but it becomes, because it is very low, it becomes less reliable as a marker of ovarian reserve. But I will show that in our paper, which is now submitted for publication and hopefully will be published soon, we compared the AMH, the low AMH to the extremely low AMH, and compared it to age of the patients. So we had patients with young age and older patients. There was no significant difference between the live birth rate in the extremely low AMH arm and the low AMH arm. They both had a low pregnancy rate of about 11 to 16%. But the live birth rate in women with normal AMH was definitely better, 30%, compared to the women with low AMH below 1, about 15%. And of course, the main factor was the age. The live birth rate was significantly higher in women below the age of 35, about 33%, women from 35 to 40, about 31%, compared to the live birth rate in corresponding age groups with a low AMH, about 18 and 13%. So definitely age is the main factor that will predict the live birth rate. And the conclusion of this study, the importance of age in determining the prognosis of IVF in patients with low levels of AMH, there was no difference in the outcome of IVF between low and extremely low AMH levels. Women with normal AMH level resulted in high pregnancy rate as compared to women with low AMH level in the same group, and it didn't really make a difference if the AMH was very low or extremely low. And I guess we all of us see those labs now coming with an AMH of 0.03 and 0.01, very, very low levels. Assessment of the AMH, you can do it manually, you can do it automated, but it seems that there is a good correlation between the antral follicle count and serum AMH using both manual and automated assays. However, automated assays were more strictly associated with the antral follicle count, especially the Alexis. In women, especially in women with a reduced AFC, it seems that the Alexis assay works better. So I put a question for you, and I'm actually going to work on this question. Should we monitor our poor responder patients and choose to start on the cycle where we see a better AFC? If this happens, maybe not all patients will have this variability. I think we need to try to work on answering this question to improve the cohort of follicles that we are producing. And finally, I just want to show you the results of our ultra-short protocol, which is the protocol that we usually advise our poor responder patients or expected poor responder patients with low AMH and low antral follicle count. And these are the results in 1.5 years from the beginning of 2016 to July 2017. All of these patients underwent an ultra-short protocol for induction due to poor ovarian reserve or low AMH. We had about 495 cases, and 80 of them were cancelled, so 85% proceeded to embryo transfer, and the overall clinical pregnancy rate was about 20%. Which I think is very good for patients expected to have a poor result. But then when we divided them according to age, again, age is the main factor. Less than 35, the clinical pregnancy rate was 24%. From 35 to 39, it was 21%, and patients above 40, 12%. As is always said, even patients with low AMH, they should not be denied to have an IVF cycle. They have a pregnancy rate, as you can see, even those above 40. But I think the key issue is the counseling of the patient. She has to know and understand the the success rate, especially in patients above 40. And if she accepts this low clinical pregnancy rate, definitely she should go ahead. And remember that the clinical pregnancy rate, these are not live birth rates, because these are very recent results, but again, the live birth rate is even lower. So we also have to counsel the patients about this, especially patients above 40, because they have a very high abortion rate of about 50 to 60%. Thank you.